which is a journal club, so tracking some recent publications in this area of mental health, severe mental illness, and integrated care, and seeing where those two meet, and then choosing an article out of the 40 or so that we find. So as you guys are probably also familiar, before we take a deep dive on a specific article, I will go over a brief topic of interest. And this one's going to kind of deviate a little bit from what we've been doing previously, because it's going to be looking at some trends. So I don't like research metrics, analyzing research publications has become a big thing, both to track researchers, but also to not so much assess researchers, but to just think about a field of research and think about who's publishing there, what are some prominent journals, thinking about whether or not those journals are necessarily the high impact journals, or maybe there's something new in the field. And I guess the overarching goal is to potentially shift people's understanding of the field that they're researching in and get them away from necessarily looking at the same journals over and over, or thinking about the same authors over and over. So with this, we've created essentially a unique data set that I'm gonna, in the next slides, talk a little bit about. And the way we've created that, Nicole Julane, who's the graduate student assistant, Jamie and I have done, is we've pulled from multiple databases and combined all those publication results, deduplicated them, and found those lists that we've been sending out to you. So that's a long-winded way of introducing it, and then we'll do a deep dive on the publication. So here's where to follow up with what I was just mentioning. So the data set, the analysis of the publications from 2020 is what I did for this presentation. So I pulled that within our database that we've created, the Best Centers Library on Integrated Care. So these are results coming from PubMed, Web of Science, EBSCO. They've been deduplicated as much as possible. From those results, I looked in our database and I pulled out results from 2020, which we had 385 in total. But out of those 385, I wanted to focus on publications that specifically had the term integrated in the title. So to avoid articles that maybe we've pulled where it's talking briefly about integrated care, but only in the abstract. So I wanted these to be more targeted to what we're talking about here. So I found 172 of those. And so then this is the search strategy that we use. So to give you a little bit more about the topic, severe mental illness, integrated care. So that's what we use to search the databases. And then out of that, basically just created a large spreadsheet and looked at things like the top journal, which is listed here. And between looking here, which is our own created data set, and also looking in Web of Science, which is a database that does a similar analysis, insight, it has that capability. I found that out of 172 publications, there's really no publications, journals that really are like runaway titles. I was wondering if there was going to be something that had 20 publications. That really doesn't seem to be the case in this field, which I guess is a good and a bad thing. It gives you an opportunity to look at a bunch of different journals. In this list, there's the Journal of Integrated Care, but there's also Clinical Practice in Pediatric Psychology, Family Systems and Health. So they all are on topic. I would hope that seems that way to you, but there's no real predominant journal. So this is where my recommendation, if anybody's doing searches on their own, which I know some of you on the call today do, either it's research or just looking routinely to find out the latest literature, is to always explore by database such as PubMed, not by journal. Because definitely in the case of this field, it's not so much that there's one journal like JAMA or the New England Journal of Medicine that can be held up as the gold standard for integrated care research, at least in terms of quantity of output. So, and the hyperlinks in this previous slide, this will get sent out to you. So all those journal titles, you can click on the results and see the results, and then you can look through the titles. So I'll recap this session in a couple minutes and advocate for looking at these in full text. This is the database, so you can explore these titles. and I hope some of these are catching your eye. And I also did frequent authors. I didn't hyperlink all of them because I figured that looking at the top author would probably be the most useful thing here. And then anybody can look up the author as well within our database by searching it from that link on the previous screen. This again tends to be often useful for researchers who want to conduct research, find collaboration networks, but I also think it can be useful, as is the case here, there is the potential that if we find ourselves with a topic that relates to one of these researchers' areas, I don't think it's too far-fetched to say that somebody here could reach out to them, because all of these people are in mission-driven nonprofit academic health centers for the most part, and they're not going to be. I'd be really surprised if they refuse to respond. So I wanted to put this here to advocate for always thinking about. There's a lot of quote unquote experts around a certain field. And it's useful to do these sorts of analyses, and that's why I'm doing it here for you, so that you're aware of who's looking at specific topics. I realize it's going to vary their publications, but they all do have publications from 2020 with integrated care in the title, and also focusing on mental health in the abstract. One final thing to mention is, this is a brief analysis that was done, is to look at highly cited journal articles, which I also feel is an interesting thing to think about. So which articles are influencing the research within the field? This can be both a good and a bad thing. I mean, hopefully it's not the case that everybody's just citing the article because it's the most popular or because it's showing up in a Google search for whatever reason based on the algorithm. This is from Web of Science. You can see here, I've sorted it by the most cited article, and this is from 2020, and it's using that search strategy, which I showed before. So if an article's been published in 2020 and it's already been cited 8 times, that's a pretty good track record. So again, the idea here is you get the slides later today. You should be able to track down the full text for some of these. I don't think this is the best thing. I don't think the popularity necessarily dictates the importance of research, especially in the short term. As opposed to the long term, because there can be a really important article that doesn't get attention for several years. But that being said, I think people should look at both. They should look at, it doesn't hurt to see which articles are being cited frequently, to think critically about why that is the case. And you can click on these links within Web of Science if you have access to Web of Science to see who's cited the article since then. So, with that sort of brief didactic within a didactic, the key takeaways are kind of what I've been harping on about. Analyzing the publication trends can be a useful exercise, I think 1 to 2 times a year, and definitely within these didactics, I want to start doing this 1 to 2 times a year because it'd be interesting to analyze 2021, see how that compares to 2020, and so on. And just to drive home, I think it's especially important if you're conducting research to think about the field you're in. If you don't know already who the people publishing a lot in that field, who's working with who, what are these networks that exist, thinking about areas for potential collaboration, because it really is topic driven. But I also think it's useful for clinicians, students, and administrators just to think about, again, their field, the latest evidence, the latest trends in their field. And as always, as will be the case with the article Nicole's about to talk about, if you find yourself wanting to get access to any of these articles and you have trouble accessing the full text, please feel free to reach out to me, to Jamie, or to Nicole. So with that, I'm going to hand it over to Nicole.
Thanks, Simon. Do you want me to take over your screen or just have you move forward as I proceed?
Sure, you can take over the screen if you want. Should I just stop sharing?
No, I'm just going to request control of your screen.
Okay, great, that works.
Well, of the shared content, not the screen, but okay. So this article focused on how a multi-state, multi-site integrated primary and mental health care program adapted their cognitive behavioral therapy programs in response to COVID-19. The rationale and process, they present the rationale and process for creating and implementing some low intensity, high yield stress management and resiliency building resources, and some of the things that they had to do to make adaptations for remote delivery, and then some lessons learned. So the Mayo Clinic as you can see, is a pretty large integrated practice that services a number of states and quite a few patients. They serve the range of ages. And the timeline of changes that they cover in this article is from March 9th of 2020 through the end of June 2020. Within their practice, they have things like curbside consults, short-term psychotherapy, targeted mental health interventions. It's really that very traditional model of integrated mental health services within a primary care practice. Oh, okay. Oh, how do I go back? There we go. So the changes in their individual and group therapy immediately upon COVID hitting is they had to rapidly reduce face-to-face services. You can see from the chart here how they went from all services to, and when in-person services had to drop off very rapidly, then there was about a 10-day window where they had only telephone services, and then they were able to add in the video services. Throughout this time period, they were able to start adding back in individual in-person appointments and eventually in-person and group therapy appointments, but they kept the virtual option available the entire time. They've had a psychotherapy tracking process or tracking database in place to look at outcomes measures, some of which they had to change some workflows around in order to manage the COVID adaptations. Most of the people that were in the practice seeking mental health services were noted for doing so related to depression and anxiety, and they were most frequently addressed with patient education, cognitive interventions, and behavioral types of strategies. During the time periods that group services were not offered, patients were offered to either engage in individual services or pick up some of the self-help resources, or just wait until groups resumed. So obviously this would take a lot of changes in workflow. One of the things is that their integrated behavioral health team, the leadership, initiated daily telephone meetings immediately upon the world shutting down, really, so that they were able to quickly problem solve new and ongoing clinical issues, administrative challenges. These meetings did decrease in frequency over time, going from daily to weekly and eventually monthly and then discontinuing. And then they also engaged very often with the practice staff. So, they're sending out weekly practice updates, having quick reference guides for step-by-step instructions, and making sure that the clinic staff who were involved in actually implementing these workflows had a voice in what the workflows should be and had some buy-in and were in agreement to it. So 2 examples that they gave of major workflow changes where they went from a scheduling process that automatically had clients, when they were coming in for the mental health services, go through some self-report measures at the beginning of the session or right prior to the session. When they went to a generic scheduling process to be able to do video and telephone visits, that took all of the auto triggers out of the electronic records. So that way, now the behavioral health staff were having to manually initiate the process within the electronic record or actually administer the self-report measures verbally and enter them. So that was a thing that they had to work out. Another thing, when you have telephone and video visits and you have to consider risk assessment for safety planning, and hospitalization procedures for patients with suicidality or homicidality, that's obviously a way different process than it would be if you had the patient sitting in front of you. So they had to develop all new processes around that. And one of the things that they did end up implementing is some templates within the electronic record to standardize what the documentation was for safety planning and hospitalization. Another thing they did is they compiled and created some low intensity, high yield mental health resources. So they compiled existing resources from external and things that they had already created internally. They focused a lot on stress, sleep, anxiety, and mood management for all ages. And this is due to not only what was anticipated, what would be the big need during the initial phases of quarantine, but also some of the reports that had been coming out of China already about what practices in China were seeing in terms of their patients and needing and around mental health resources. So they compiled a bunch of things. They made them all electronic and all available online. They also pushed these resources out to schools so that they could get to pediatric populations. And in this, they eventually developed a new resource, the tips to help manage stress related to novel coronavirus, which would not only describe stress and the symptoms, but focused on core components of stress management and building resiliency around behavioral activation, social connection, cognitive challenging, and relaxation. This eventually turned into an interactive e-learning module that contained things like knowledge checks that you didn't have to actually get all of the questions right to move to the next section. It was just to test your own knowledge. Did you understand the concept? And some of it was concepts and some of it was actually interactive skills. So there'd be an interactive component to it. And patients could put in their own goals. So there would be, steps to actually have patients step back and say, I'd like to create a goal around this particular thing. They had to make some changes to psychotherapy as usual. So one of their major components are theoretical methods that they use and that you see commonly used within these types of practices, because it is intended to be brief therapy. Mental health services within a primary care center are not necessarily intended to be long-term mental health services. You shouldn't be in therapy for 5 years if you're getting your therapy from a primary care practice, in theory. So these briefer interventions are intended, to be able to get people on and moving forward. And if they do really need long-term psychotherapy, referring them on. So cognitive behavioral therapy, motivational interviewing, and mindfulness are, they're heavy leans. But under COVID-19, they needed to also help people evaluate negative thoughts related to specifically what was going on with the pandemic. And unfortunately, at times, some of the negative automatic thoughts were true, which then made the focus of therapy shift. Instead of looking for a way to disprove the accuracy of some negative thoughts, maybe considering whether or not the thought was helpful or compassionate, even if it was accurate. Then there was another big push on the emphasis and importance of health promotion behaviors. The reestablishment of some kind of quasi-normal routine through sleep hygiene, behavioral scheduling, diet, physical activity, and socializing. They utilize daily logs as behavioral activation strategies to help keep people moving forward. They did note some themes specific to COVID-19 during this time process or time period. You can see that this list here is the things that were coming up for people a lot. And I think it's fair to say that these are themes that we all have considered in the last year. Worries about the susceptibility and transmission of the disease itself, general uncertainty, civil unrest, particularly following, I didn't mean to change that. Oops. Questioning the severity of the pandemic, civil unrest following George Floyd and the killing of George Floyd and the many protests. Then that just kind of circled itself throughout the entire year, as we saw. Like I said, that this paper was reflective. They looked at a 3-month window, where obviously the entire year of 2020 was a bit chaotic. So I'm sure that these negative thoughts probably just increased or expanded to even the staff. It'd be safe to say. So lessons learned, the big pieces. And I think that these are important lessons learned and important things for us to continue to learn from, because while they were looking at that 3-month window, we're still all in this process of trying to transition back to some semblance of a new normal. Clear and consistent communication. So the regular brief meetings, having actual meetings, figuring out how to do curbside consults by video, making sure that people are talking and having some kind of FaceTime, whether that's on Zoom or actually in person. Leveraging the knowledge and skill of your entire team and making sure to have collaborative decision-making, not only in the workflows, but within patient care. So keeping that team mentality at the forefront. Prioritizing problem solving. And this seems very common sense, but making sure to address the most important thing first. And what they note in the article is that from the Mayo Clinic, their primary value is the needs of the patient come first. But that wouldn't be the case in every practice, and it might not be the most important thing in anybody else's specific practice, but that's what drove their practice and allowed them to make these decisions, really focusing on, well, what are the needs of the patient first? Flexibility and having the need to continuously be flexible, because as every one thing changed, 10 things also change in response to it, and continuing to be willing to be flexible and creative. Using a population-based approach, which they did note within this, it was important to keep patients in the decision-making process. Let patients have a voice in that. Also having stepped care options, so knowing that you have the lowest level option of being able to refer to resources and online modules, to actually individual and group therapy, or referrals to a higher level of care if needed. And provider self-care. That was a huge theme, and we've seen that throughout the year. I mean, we see that every year, but in the last year, I think that it's become more and more evident how important, particularly for those on the front line of any of this, maintaining our own self-care. You really can't give from an empty cup. And that was about that. So any thoughts or questions? I'll give you your